event. Dermatoscopy, as it started off, fortunately, I was a part of this team from the very beginning, though my contributions are very little, but I know that how much effort is behind this. So I would like you all to be a part of it from heart and soul. If you are here, I expect that we have a lot of national and international speakers. They have all their expertise. You are going to take a lot back home today, and do not leave it here. We are going to continue with this journey. I'm Dr. Ima Shaheen, and I'm serving in Lahore General Hospital as a senior registrar, and I am a part of the dermatoscopy team. And today we are going to steer through this a little bit difficult journey, but I believe that those who are leading us are going to make it really easy, enjoyable, and phenomenal for all of us. Thank you.
So let's start this beautiful event with the recitation of Holy Quran. And for this, I would like to invite Dr. Wajahat on the stage.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. Translation. In the name of Allah, the Merciful, the Compassionate. Recite in the name of your Lord who created man from a clot of congealed blood. Recite, and your Lord is most generous, who taught by the pen, taught man what he didn't know. Sadaqallahul Azim.
Thank you very much, Dr. Wajahat, for starting off in the name of Allah. And as it was in the Holy Quran, that we have been created to learn. This is a duty, being a creation of the Almighty. And we are all here to learn to fulfill this duty. Before we move on any forward, I would like all of you to rise for the national anthem, because we are bringing something which is very important to Pakistan, and we are all here to serve Pakistan. Rise for the national anthem, please. Thank you very much. Now we'll move on to the formal proceedings of the session. As I said, that this dermoscopy has been brought to Pakistan and brought to the limelight, by the way, for the very first time in our history. We are all very proud of our country, and let's make our country proud of us. But before you start off anything, a single person cannot do anything. We are all well aware of this. And here I would like to say, Fard kaim rabte millat se hai, tanha kuch nahi. When we started this journey, I bring forth my those memory that our president, Professor Tahir Jameel Ahmed, one day called Aisha into her office and handed over her some gadget. We were a little bit aware, but not very well aware of what was it. He not only recognized the need of dermatoscopy, but he also recognized the potential in our beautiful general secretary that she can take this thing forward and she can bring something new here. That started off there, but still a team was needed. And we'll go into detail a little bit more into the session. But once the things have been done, we needed more and more people. And finally, the things have got to this date. But on that day, we needed a person who could patronize. So Aisha thought of a person in which department she was working. She's otherwise a very dynamic lady and always open to new challenges. And I hope this stays like this forever. No, none other than the head of Department of Dermatology, Unit 2, Dr. Zaida Rani. Madam, please come on to stage
We would
for the
like
welcome address.
we would like to invite Professor Dr. Zahida Rani on the stage for the welcome address.
Assalamu alaikum. Uh, I'm I am overwhelmed by the energy of these people who have had the vision to develop such a association, which is for the first time in Pakistan that you're doing. And I feel proud that most of these people who have created this association are part of my journey of dermatology as well. And I believe that dermoscopy is the future of clinical dermatology everywhere in the world. So the initiative taken by these people, my respected teacher, Professor Tahir Jameel, from whom I learned so much, and Dr. Aisha Ghias, very dynamic. She has such great potential, and I feel proud that she's still with me, working in my department. And Ima Shaheen, I've had the opportunity to work with her, Umar Mushtaq, everybody, Dr. Wajia Nusrat. So I know these people personally, and I believe that they will take this speciality to new and greater heights. I welcome you all. Professor Babar Rao came all the way from America to be here with us. Professor Tariq Rashid, Professor Shahbaz Aman, Azam Bukhari Saab, Sir, you have been a mentor to so many good people. Professor Atish Azad, Professor Khawar Khurshid, Professor Lamis, everybody, Saila, Dr. Nabila Shehzadi, and all the other participants who are very dear and near to me, and my own department, all the medical officers, the consultants, the PG trainees, the house officers, they all participated in bringing you this successful event. I welcome you all and thank you very much.
Thank you so much, Professor Dr. Zahida Rani, for your wonderful words. Now, I would like to invite the person without whom this dots would never have been possible. He has always encouraged us in the era of aesthetics that you should never leave conventional dermatology, as you guys are true dermatologists and you have to hold hands to carry this legacy. He has been a teacher of almost all of us, and he has served almost all the medical colleges and all the hospitals as a professor. I would like to invite the president of DOTS, Professor Dr. Tahir Jameel.
And I would take a liberty to say a few words about him. He is that person. I would disagree with you, Dr. Umar. Aesthetics is very much part of dermatology. And I have learned this from you, sir, that you welcome everything. You became the first drop of rain, and it's very difficult to be the first drop of rain in totally drought struck area. It's not just dermatoscopy. He has brought in all those laser therapy, and he is my mentor and I would say inspiration for dermatosurgery. But sir,
Last but
today,
not least, dermatosurgery. He has been an excellent dermatosurgeon as
and he
well.
promotes aesthetics and he promotes pediatrics. He promotes everything. Sir, thank you very much for giving us that inspiration. Dr. Tahir Jamil Ahmed, the president of Dermatoscopy, Onychoscopy, Trichoscopy Welfare Society of Pakistan. Sir,
Thank you very much. I'm honored. Can I have my first slide? Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Wassalatu wassalamu ala Rasulihil Kareem. Forward. With the permission of my dear friend Babar Rao, who has traveled all the way from US, on just a little request, can I start, sir? Okay. My dear friends, colleagues, ladies and gentlemen, Assalamu alaikum and good morning. It's my proud privilege to welcome you all on this auspicious occasion where we are going to launch a new platform, new academic platform. It was causing interest. And that academic platform is now luckily made in the clinical aspects of dermatology, which was long forgotten. And this is going to make us more wise clinicians afterwards, inshallah, and that will make us more efficient and more conscientious doctor treating our patient, inshallah. So basically, it started in 2016 that I went to USA, purchased a dermatoscope, and handed over to very young, energetic Dr. Aisha, and said, now it's your duty to make a team and few SOPs so that we use this for almost for almost all the skin conditions, not only for pigmentations or cancers. We are going to use it for everything. So that day, till date, we have reached to a stage that we can say that yes, now we have a platform on which we can disseminate this knowledge to all of us. And that day, when we started, I said, this is now a new era of excellence in dermatology. So that 2016 and 2025, 9 years led us to this stage that we have reached a society we call Dermoscopy, Onychoscopy, Trichoscopy Society, which is a welfare society. So welfare for what? So it's going to be a welfare for the doctors so that there is learning experiences, and welfare for the patient, and welfare for the patient that they are going to inshallah get a quick, economical and more efficient treatment modalities. So how this is going to happen? Yes, a small gadget called Dermoscope. So do you know why we have written this? From patterns to precisions, connecting the dots. Do you think it is something novel idea? Anybody, any comments? Have we started something new in the history? दोबारा पढ़ के देखें. गुड. उससे भी पीछे चले जाएं. बहुत पीछे चले जाएं. What is this? Sky studded with stars. Some very bright stars, some twinkling stars, some alone stars, some in the groups. So everybody say, oh, wonderful, looks good. But when you have eye, you start counting, you start concentrating, and then you see these are not dots. They are something more than dots. Then you start making out some of the precise pictures. Okay? So those pictures are called patterns. फिर क्या हुआ था? People started making patterns out of it. And then they said that patterns are at times fixed, at times mobile. So the logic led to these patterns to a precise answer. And what was that answer? Thousands and thousands and thousands years ago, GPS of that time. People used to travel dark oceans and deserts, and they used to reach safely to the destinations. So those were the dots. इसीलिए अल्लाह ताला ने फरमाया था ना कि जो लोग गौर करते हैं उनके लिए इसमें निशानी है. अच्छा, यही स्काई है, यही स्टार थे. कुछ लोगों ने और ने इसमें मेहनत की. And you know, from the same dots and from same patterns, they reached to 12 zodiac signs. And that was start of a new science, astrology. फिर हम गाइडेंस लेते हैं कुरान से, तो अल्लाह पाक कहते हैं बस समा इज़ातिल बुरूज, कसम खाता हूँ उस आसमान की जिसमें मैंने बुर्ज या मीनार बनाए. तो दीज ज़ोडिएक साइंस आर बेसिकली पिलर्स. अब देखें ना, वही डॉट्स हैं, वही पैटर्न्स हैं, प्रिसीजन उनको कहाँ ले गया? साइंस. एक और एग्जांपल दे देते हैं. दीज आर वेरियस पैटर्न्स. किसी ने गौर किया तो पता चला ना कि जी बिलियंस ऑफ पीपल बट नो टू मैच, तो इट बिकम्स आइडेंटिफिकेशन. किसी और ने इस पर गौर किया तो देन इट बिकेम समटाइम्स योर कैरेक्टर्स, साइकोलॉजिकल इंस्टिंक्ट्स, सम ऑफ द डिजीज पैटर्न्स ऑन. तो लेकिन एक बात, मेरे जैसा भी था, उसने और गौर किया, उसने कहा नहीं, देयर इज लव, देयर इज लाइफ, देयर इज लक. सो दे स्टार्टेड गिविंग यू प्रेडिक्शंस अबाउट योर लाइफ. सो साइंस गोज लाइक दिस. अब हमने क्या किया? अब आप ये देखें ना कि डर्मोस्कोप है आपके पास, आ गई है, आप करें. क्यों नहीं कर रहे? 2016 and now 2025. I'm not talking about Panu Akel, I'm not talking about Chichu ki Miliya, Lahore, where we have more than 20 teaching institutions of dermatology. How many have a dermatoscope? किसी को पता है? I think not more than 4 or 5, ऐसे ही है ना? So that means even sitting in Lahore, 70% of the qualified and qualifying dermatologists have never handled a dermatoscope in their hand. जबकि पता है कि पहली dermatoscope कब यूज हुई थी? 1655, and that was used for nail bed capillaries. आज भी it is not available. सबसे बड़ी बात है, नॉट अवेलेबल टू इवन, आई एम सॉरी, मैं कहना नहीं चाहिए, मेरी तरह के कई प्रोफेसर हैं जिन्होंने आज तक पकड़ के नहीं देखी किस तरह करनी, पढ़ाना तो दूर दी. ठीक है ना? इसलिए कहा कि नाउ दिस इज नीड ऑफ द टाइम, बिकॉज इससे होना क्या है? होना यह है कि इतना सा गैजेट आपको और आपके पेशेंट को कितनी चीज़ों से बचाता है. प्लीज कीप इन माइंड, इट्स नॉट ओनली कैंसर, एवरी स्किन डिसऑर्डर. फॉर एग्जाम्पल, यू आर सिटिंग इन योर क्लिनिक and you find something bad in the hair. What do? You clip the hair, send it to the lab, see it in the microscope, it will come, it was trichoexis nodule. Oh, while in the clinic you just put a dermoscope, you see, and it's finished. तो इसलिए that was the need कि हमें कोई ऐसा clinical platform हो कि जब availability नहीं है, whatever we have, we offer you all. ठीक है ना? इसीलिए इंपॉर्टेंस डायग्नोस्टिक हो, प्रोग्नोस्टिक हो, सबको पता है, बट इट वाज नीड ऑफ द डे टू ब्रिंग इट टू यू. अब ये जब सारा कुछ हो गया ना, तो इसमें क्या था कि हम एक रजिस्टर करा लेते और काम शुरू कर देते. वी हैड टू रन 3 continuous years फ्रॉम पिलर टू पोस्ट. कभी एक थाने में, कभी एक कचहरी में, कभी एक पेपर के लिए, कभी एक फाइल के लिए, कभी एक बायोमेट्रिक के लिए, और कभी एक हाजिरी के लिए. एंड यू नो, I salute to this guy called Zargan and his team. हम लोगों ने खत्म हो जाना था. And that's how we reached the level that now I'm standing in front of you saying, yes, please come and join us. अच्छा, अब जो है मिशन और विजन की जहाँ तक बात आती है तो बड़ी सिंपल सीधी सादी बात, नो लॉन्ग थिंग्स. We are going to have a platform in the country and we are going to disseminate not only knowledge, we'll make it scientific that wherever we go, a seminar or webinar or workshop, at the same time, side by side, we are going to collect the data so that we have our own original data of disease and its spread. At the same time, we'll also locate local researchers and internationally, of course, with the liaison. Definitely, we'll be at par with them. We'll exchange our notes, and definitely, we know the differences or similarities of our diseases, their patterns, and their behaviors. So all these things, they are in our portfolio. And how are you going to, you will say, okay, how we are going to disseminate this? So I'll request persons, great people like Baba Rao and Asma, to please continue their efforts with us in future as well. And of course, yes, my team. Professor Rabia, कौन सी? अच्छा, हाँ, look at it. Dr. Professor Rabia, she has come all the way and she is taking care of the whole Sindh. Then Shavana, the Pindi guy, Pindi girl, sorry. And then my team, Aisha, Iman, Wajiha, and then the two robust people. So they are the one who are going to make, inshallah, everything go smooth and reach every one of you, inshallah. I want to mention two, three people who have been with us, like Rashid Saab from Serving Health, from Martin Now, and from Nabi Qasim. They have been of great help to us. But all my dear colleagues, I'm so grateful to you. You've made it possible. You all came early and you made it a proud moment for me. Thank you very much for coming. Pakistan Zindabad.
Thank you very much, sir, for emphasizing on the importance of dermatoscopy. All of us, when we became doctors, we knew that we would be having a stethoscope. Or many of us who wanted to and who dreamt of becoming a doctor right from day one just kept on carrying a stethoscope and a wallet around. But when I came into dermatology, I was very much a medicine person, but dermatology gave me the thought that you can combine the medicine and surgery together. But here I thought that the stethoscope, which was once like an identification of doctor, is no longer with me all the time. Then we thought that there should be something special to a dermatologist as well. And that thing is a dermatoscope. And once Aisha told me that dermatoscope is considered as a third eye of the dermatologist, I think it's more important or yet equally important as the other two eyes. It is important not only in our conventional dermatology, but it does find its uses in the aesthetic dermatology as well. And here I am advocating that every kind of dermatology is important to us. Um, let's not waste more time. I have emphasized a lot, and I think the person who can tell you the importance of dermatoscopy and how all this came into being here in Pakistan is none other than my dear friend and the General Secretary of our society, the first registered society in Pakistan of the doctors. It's a registered society, by the way. And now I would like to invite the Ruhe Karma, the Ruhe Rama. Dr. Umar, please, some words too.
I would like to add a few words that Dr. Aisha Ghias is undoubtedly a live wire in the field of dermatology, and we are all blessed to have such an amazing senior and such a competent dermatologist
Dr.
among
Aisha
us.
Ghias, please a big round of applause because nothing could
Please
have been
welcome Dr.
possible
Aisha
without her.
Ghias.
मैंने कहा इन लोगों ने बोलते रहना मैं आ ही जाती हूँ तो मैंने अच्छा किया मैं आ गई बिफोर आई स्टार्ट क्योंकि कि मैंने बहुत ही इंपॉर्टेंट 10 मिनट आप लोगों के लेने हैं जस्ट टू टेल यू कि हाउ मच एफर्ट डिड इट टेक टू रीच टू दिस डे And I would like to have attention of you all, but before that, I would love all my seniors who we plan to be the panel of experts in the first session. So I would take the liberty to call up again Dr. Ima and Umar. Please seniors को बुला लें क्योंकि सीधे बैठे होंगे तो मेरा दिल और बड़ा हो जाएगा.
टेकन मैडम आयशा, और मैं खुद लाइक आंखें चुरा रही थी, बिकॉज वॉट आई फेल्ट वी कैन नेवर बी वॉट वी आर टूडे विदाउट आवर टीचर्स. And as I said about Dr. Tahir Jameel, there is another visionary. And the other day I also said that whenever I hear this word visionary, the face that comes into my mind is sitting right in front of me. He is the person who has this honor of being the supervisor. And I would say that he's not just a supervisor, he's a father figure, he's a patron, and he's a lot. And everybody knows him, but here I would say a few words about him. He has served the Department of Dermatology for more than 40 years now. He has trained a lot of very renowned dermatologists of today who are serving the country and who are serving abroad as well. He is an author of more than 100 publications. He has also written 4 books, and he is none other than Professor Dr. Shehbaz Aman. Sir, please come on to stage.
सर शहबाज अमान मेरे सुपरवाइज़र भी हैं और मुझे लगता है कि अब्बू जान के बाद मुझे ये बिल्कुल एक सेकंड अब्बू जान लगते हैं और मैं सर को अक्सर कह भी देती हूँ और सर भी मुझे बहुत खुशी है कि सर मुझे हर मौके पे बेटी समझ के गाइड करते हैं क्योंकि सर को पता है कि वो जो भी कहेंगे तो मैं डेफिनेटली उसको बहुत सीरियसली लूँगी और उस पर काम भी करूँगी. नेक्स्ट.
Warm welcome, Professor Shabazz Aman. Now, our second panel of expert is another fatherly figure. Without a doubt, he is one of the greatest teacher I ever personally had. Though he was not my supervisor, ना वो हमारे hospital में थे. He was from a different hospital, लेकिन he was such a compassionate teacher. He was such a passionate teacher कि उनसे पढ़ने हम दूसरे हॉस्पिटल्स भी जाते थे और उनसे पढ़ना अनडाउटेडली एक शर्फ से कम नहीं है. He has been a professor for many years in Gangaram Hospital, and he is none other than Professor Dr. Tariq Rashid. He was my examiner in FCPS long case as well. बहुत ज़्यादा सर ने क्वेश्चंस पूछे थे, लेकिन एट द एंड ऑफ द डे इट वेंट वेल. सर ने मुझे पास कर दिया था. थैंक यू सर, आपकी वजह से आज मैं यहाँ खड़ा हुआ हूँ.
The next person is a dermatologist who makes all female dermatologists proud. She is currently serving as head of Department of Dermatology, Jinnah Hospital, Lahore. She is a great daughter, born to a great father, Professor Mahmood Ali Malik. And in addition to being a teacher, a dermatologist, her specialty is medical education. One of the very first MCPS, CHPE, and now she's also serving in medical education in Allama Iqbal Medical College and University of Health Sciences. My words are going to fall short. Please, madam, come on to stage, Dr. Lamis Malik.
Please welcome Professor Dr. Lamis Malik.
The next person, I would say, like there are many people with many qualities, but the person from whom I learned how to do things the way it's fair, that making difficult things look easy. He is the person who combines and aligns the static dermatology and the conventional dermatology in such a subtle way that you don't even feel the difference. He's the person who not only has a great knowledge of himself, he's open to the upcoming things. He's always up on learning and then teaching it to the rest of the people. I have the honor of currently working under his supervision, the head of Department of Dermatology, Lahore General Hospital, Professor Dr. Atif Shehzad.
He is like a big brother to us, and he is also a very compassionate and a very passionate dermatologist with very good lasers, with very good practice of lasers as well. And he is very much into conventional dermatology as well as aesthetic dermatology. We welcome Professor Dr. Atif Shahzad. And now, please, Dr. Aisha, you can carry on with your session.
Thank you very much, Dr. Umar and Dr. Ima Shaheen. My talk is not very long. It's all about the journey that we had in the previous 3 years. कहना आसान है लेकिन 3 साल की efforts हैं. आपको अगर लग रहा हो कि आपको हम बोर कर रहे हैं और अभी तक हम scientific session के साथ start नहीं किया है, तो it's going to be the last thing that I say in front of you और उसके बाद हम scientific session को आगाज़ करेंगे. तो लगा दें जी. फ्रॉम ड्रीम टू रियलिटी, मैंने इसका नाम रखा है जी फ्रॉम ड्रीम टू रियलिटी, क्योंकि इट वॉज नॉट लेस देन अ ड्रीम. और मेरा एक ख्वाब था जब सर ने मुझे कहा कि आपने डर्मोस्कोप सीखनी भी है, पढ़ानी भी है, लेकिन मुझे आती नहीं थी. ऑनेस्टली स्पीकिंग, द ओनली थिंग आई न्यू अबाउट डर्मेटोस्कोपी वाज अ ब्लू वाइट वेल, और वो भी एक रुख शरीफ में पढ़ा था कि देयर इज अ ब्लू वाइट वेल. उसके अलावा मुझे कुछ नहीं पता था कि डर्मोस्कोप में क्या होता है. एंड देन 2-3 हफ्ते बाद सर ने कहा, हाँ जी, व्हाट इज द प्रोग्रेस, where is the data you are keeping, how many patients have seen with the dermatoscope, and I was blind. और उस दिन मुझे बहुत ही शर्मिंदगी हुई कि सर ने मुझे गैजेट एवं ही नहीं दिया. ही इज गोइंग टू आस्क मी कि आपने किया क्या. फ्रॉम देयर ऑन फिर हमने इसके ऊपर काम करना शुरू किया. सो आई से फ्रॉम ड्रीम टू रियलिटी. अच्छा, ये जो सर ताहिर ने भी आपको बताया कि दिस इज आवर मेन स्लोगन, ये जो बॉटम पे आप देख रहे हैं, फ्रॉम पैटर्न्स टू प्रिसीजन कनेक्टिंग द डॉट्स, और इस स्लोगन के पीछे भी काफ़ी एफर्ट है क्योंकि वी वांटेड टू से इट ऑल. तो जब हमने स्टार्ट की थी, वी हैड दिस डर्मोस्कोप ऑन द टॉप राइट, फायरफ्लाई प्रो. ये इसकी कॉर्डलेस थी और इसको सिस्टम में हम इसकी पिक्चर्स देखा करते थे. वी यूज टू डू दिस एंड देन सी द पिक्चर्स इन द कैमरा. ये मेरे फर्स्ट बैच ऑफ ट्रेनीज थे उस वक्त जो मेरे साथ हैं, जिनको मैंने ट्रेन किया था डर्मोस्कोपी के ऊपर. लेकिन कुछ प्रॉब्लम्स थे उसमें. मैंने इस तरीके से मैं फोल्डर्स बनाया करती थी डर्मोस्कोपी केसेस के, और उसमें मैंने डिफरेंट फोल्डर्स बनाए. मुझे कोई आइडिया नहीं था. इट वाज रियली न्यू टू मी कि मैंने ये डर्मोस्कोप तो चलो मैं कर लेती हूँ, मैं इसका डेटा कैसे रखूंगी. कुछ पिक्चर्स मैंने इस तरीके से बनानी शुरू की. बॉटम पे आप देख सकते हैं ईमा शाहीन लिखा हुआ है. कि ईमा को भी नहीं पता कि इस स्लाइड में इसका नाम भी है, क्योंकि ईमा एंड मी वर वर्किंग टुगेदर बैक देन. और इसके कोई मोल्स वगैरह थे, उसकी मैंने पिक्चर्स बनाई. अच्छा, पिक्चर्स की क्वालिटी अगर आप देखें तो इट्स नॉट वेरी गुड, इट्स नॉट वेरी गुड. बट उस वक्त मुझे ये भी नहीं पता था कि इसकी पिक्चर्स की क्वालिटी अच्छी नहीं है. बहरहाल मैंने इस तरीके से पेशेंट्स के नाम के साथ, डेट के साथ इनको सेव करना शुरू किया. मुझे लगा ऐसे ठीक लगेगा. देन आई रियलाइज्ड कि अगर क्लिनिकल पिक्चर नहीं है तो डर्मोस्कोपिक पिक्चर देने का फायदा कोई नहीं है. हाउ एम आई गोइंग टू कोरिलेट देम, सो आई नीड टू हैव द क्लिनिकल पिक्चर्स ऑल्सो. उसके बाद मैंने इस तरीके से क्लिनिकल पिक्चर्स का भी डेटा रखना शुरू कर दिया, बट देन उसने भी कोई पर्पज सर्व नहीं किया. देन आई हैपन टू मीट डॉक्टर ईमा शाहीन. हम इकट्ठे काम कर रहे थे. फिर मैंने कहा यार इसका करें क्या, सर तो हर कुछ दिन के बाद पूछ लेते हैं. इंतहाई शर्मिंदगी होती है, सर को मैं क्या बताऊं कि मैंने क्या केसेस देखे, क्या बना क्या नहीं बना. प्रॉब्लम हमें आ रहे थे रिकॉर्ड कीपिंग के. फिर हमने कुछ बुक्स ऑर्डर की, अमेजोन पे बुक्स ऑर्डर की. पाकिस्तान में कोई अवेलेबल नहीं थी. माय ब्रदर इज़ वर्किंग इन यूके, सो हमने अमेजोन से वहाँ बुक ऑर्डर कराई, यहाँ मंगवाई, उसकी प्रिंटेड कॉपीज़ बनाई, उसको खुद पढ़ा. हर इंस्टीट्यूशन में एक एक कॉपी दी कि हम पढ़ें, उसको समझें. फिर प्रोफेसर ताहिर जमील से रिक्वेस्ट करके हमने टेबल अरेंज किया, एक सिस्टम अरेंज किया जिसके अंदर हम ये सारा डेटा रखें, क्योंकि मुझे लगा कि इतना डेटा मैं डेली अपना सिस्टम तो नहीं कैरी कर सकती. ऑनलाइन ट्रेनिंग कोर्सेज हमने निकाले, ऑब्वियसली जो फ्री थे, और मोबाइल ऐप्स भी काफ़ी सारी फ्री हैं जो आपको डर्मोस्कोपी ट्रेनिंग कराती हैं. तो हमने वो सारे जो रिसोर्सेज थे जो फ्रीली अवेलेबल थे, उन सबको हमने एंगेज किया सीखने के लिए. लेकिन उसके बाद कुछ प्रॉब्लम्स थे कि कोई पैटर्नेज नहीं थी. मैं अगर कोई पिक्चर देख रही हूँ कि इफ इट्स अ मेलानोसिटिक नीवस और इफ इट्स अ सोलर लेंटिगो, हु इज टू कंफर्म, मैं किससे पूछूं कि भाई यही है जो मैं कह रही हूँ या ये कोई और चीज़ भी हो सकती है. तो कोई पैटर्नेज नहीं थी, कोई बंदा नहीं था उसको वैलिडेट करने के लिए. स्टैंडर्डाइजेशन का प्रॉब्लम था. डेटा कीपिंग अगेन एक मसला बनी हुई थी कि हम किस तरीके से डेटा को रिट्रीव करेंगे, फॉलोअप कैसे बुलाएंगे, और इसके ऊपर हमने रिसर्च कैसे लिखनी है, जो मेन पर्पस था सर ताहिर जमील का कि इसके ऊपर रिसर्च चले. ये मुझे आप चेंज ही कर दें. वे इज द सिस्टम जिसके साथ ये कनेक्ट होता है. ओके, सो देन सम ऑनलाइन कोर्सेज आई हैड टू लुक फॉर, जिसमें ये हेल्थ सर्ट के कुछ कोर्सेज थे. पहले प्रोफेशनल सर्टिफिकेशन की, उसके बाद एडवांस्ड सर्टिफिकेशन की. कुछ वर्कशॉप्स हमने कराई, कराची में कराई. डॉक्टर राबिया गफूर वाज वेरी विजनरी बाय देन. इन्होंने कहा कि अगर आपको आ गई है, आपने कुछ सर्टिफिकेशंस की हैं, तो व्हाई नॉट कम टू कराची एंड डू इट देयर. वहाँ पे हमने वर्कशॉप की. उसके बाद कुछ इस्लामाबाद में हमने वर्कशॉप की. वहाँ प्रोफेसर बाबर राव भी थे, तो बड़ा अच्छा वो भी. इट वाज अ वेरी सक्सेसफुल इवेंट एंड इट वाज द विजन ऑफ डॉक्टर शबाना शरीफ, जो अब ये दोनों मेरी टीम में हैं. डॉक्टर शबाना हमारी टीम में है, डॉक्टर राबिया हमारी टीम में है इस वक्त, डॉट्स की टीम में. देन वी हैपन टू डू फ्यू वर्कशॉप्स, शालीमार में की, पैडकॉन पे प्रेजेंट किया, डॉक्टर खावर के साथ जो पिक्चर है वो पैडकॉन में डर्मोस्कोपी के ऊपर मैंने टॉक प्रेजेंट किया, एंड एवरी ईयर आई हैपन टू डू सो। मैंने तकरीबन 5 से 6 साल लगातार ये किया। कुछ मैंने फिर जो थे ये कंप्लीट कर लिए कोर्सेज, पिंक लीजन, मिकोजल लीजन्स, जो भी डिफिकल्ट आगे एडवांस डर्मोस्कोपी कोर्सेज में चीज़ें आती हैं, और कुछ जो हैं वो ऑन गोइंग अभी मेरे इन प्रोग्रेस चल रहे हैं, क्योंकि ऑब्वियसली ये टाइम टू टाइम आपको चलता रहता है, यू आर ऑन इट। देन वी क्रिएटेड अ व्हाट्सएप ग्रुप जिसके आप सब लोग मेंबर्स हैं, मोस्ट ऑफ यू आर मेंबर्स ऑफ दैट व्हाट्सएप ग्रुप, वी हैव 845 मेंबर्स। इसमें लोग अपनी पिक्चर्स शेयर करते हैं डर्मोस्कोपी की, और उसके ऊपर सब लोग कमेंट करते हैं, मैं भी उसमें कमेंट्स करती हूँ। सर बाबर राव इज ऑल्सो उसी पार्ट ऑफ द ग्रुप, और सर भी अक्सर कमेंट कर देते हैं पिक्चर्स के ऊपर। तो इस तरीके से भी हमने थोड़ा सा अपनी लर्निंग को एनहेंस किया। लेकिन उसमें अगेन देवर प्रॉब्लम्स कि इट शुड नॉट बी अ वन मैन शो, इफ आई एम नॉट देयर नोबडी वुड यूज टू रिस्पॉन्ड। तो मुझे लगा कि इट शुड नॉट बी अ वन मैन शो कि मैं हूँ, अगर मैं नहीं हूँ तो कोई रिस्पॉन्ड नहीं कर रहा है, तो वी शुड हैव अ टीम ऑफ पीपल जिन जो सब लोग वेल अवेयर हों और जो सब गाइड कर सकें, और डेडिकेटेड पर्सन टाइम टू टाइम चेंज होना चाहिए जिसकी रिस्पॉन्सिबिलिटी की वो इन सारी चीज़ों को देखे। पिक्चर क्वालिटी व्हाट्सएप पे ख़राब हो जाती है, यू ऑल नो। आप लोग जो पिक्चर भेजते हो उस ग्रुप में डर्मोस्कोपी के लेने के लिए, इंसाइट लेने के लिए, तो उसकी पिक्चर क्वालिटी ख़राब हो जाती है, और उसमें वो इन्फॉर्मेशन मुझे नज़र नहीं आ रही होती जो आप अपने फ़ोन से कैप्चर करते हैं, जो आपके सिस्टम में पिक्चर पड़ी होती है। तो देर इज़ अनदर प्रॉब्लम। जब हमने ये बात की आईटी वालों से, उन्होंने कहा आपको ओरिजिनल पिक्चर चाहिए होती है, आइदर गेट इट थ्रू मेल और ऑन द वेब, व्हाट्सएप के ऊपर आप लोगे तो ये ख़राब हो जाएगी। देन प्राइवेसी और हेजिटेशन है, मैं ये नोट करती हूँ ग्रुप में अक्सर लोग हेजिटेट करते हैं चेक पिक्चर्स अपलोड करने पे और उसके ऊपर ओपिनियंस लेने पे थोड़ा हेजिटेट करते हैं। एंड देन ऑब्वियसली डेटा प्रोटेक्शन का मसला था। अब इन सब चीज़ों के सोल्यूशंस जो मुझे उस वक्त समझ आए कि मुझे टीम बिल्ड करनी है, वॉलंटियर वर्कर्स मेरे पास होने चाहिए, नेशनल और इंटरनेशनल प्रोजेक्शन के लिए मुझे लोगों को लेना था। प्रोफेसर बाबर राव, ही इज़ बीन काइंड इनफ टू से येस टू एवरी विश ऑफ माइन, और हमने सर को खींच तान के इसमें इंक्लूड किया। फिर हमने स्किन ऑफ कलर में अब डेटा जनरेट करना शुरू किया है, बिकॉज वी आर शॉर्ट ऑफ डेटा, और उसी की बेस के ऊपर हम अपने जो है एआई को भी ट्रेन कर सकते हैं और अपनी रिसर्च भी जनरेट कर सकते हैं। वी नीड टू हैव कोलैबोरेशन प्लेटफॉर्म्स, और ऑब्वियसली वी आर नॉट हैविंग एनी कैंसर रजिस्ट्री इन पाकिस्तान, इट्स ओनली वन विच इज इन शौकत खानम, एंड द सेकंड वन इज इन कराची। सो एट द मोमेंट वी आर नॉट हैविंग एनी कैंसर रजिस्ट्री एट नेशनल लेवल। तो ये भी एक जहन में था कि ये काम भी करना है। तो हमने इसके ऊपर 2021 में शुरू किया था। वी हैव बीन टू वेरियस गवर्नमेंट ऑफिसेज इन द लास्ट 3 years, एंड फॉर मतलब मैं तो ये नहीं कर सकती हूँ, कोई भी डॉक्टर शायद नहीं कर सकता है कि आपने सरकारी दफ्तर में जाना है, वहाँ 2 घंटे एक बंदे का वेट करना है जो कि क्लर्क कहलाता है, और उसके बाद वो आपको ये कह के भेज देता है कि नहीं डॉक्टर साहब ये डॉक्यूमेंट भी लेकर आएँ, एंड यू कैन नॉट इवन से कि ये आपने मुझे पहले तो नहीं बताया था कि ये डॉक्यूमेंट भी लाना है। बट दिस माई हस्बैंड वॉज विद मी, मोहम्मद जरगाम हैदर, ही इज ऑल्सो पार्ट ऑफ डॉट्स। तो ही हैज़ बिन टू वेरियस गवर्नमेंट ऑफिसेज अलॉन्ग विद द एडवोकेट, और इसमें एक नाम मैं ना लूँ तो ज्यादती हो जाएगी, वो चौधरी राशिद साहब हैं सर्विंग हेल्थ से। तो ही इज द मैन के जो कांस्टेंट पुश करते रहते, मैडम आपने हिम्मत नहीं हारनी, मैडम आपने हिम्मत नहीं हारनी, वी आर विद यू। आपको कोई सरकारी काम है, जरगाम साहब भी नहीं जा सकते, आप हमें बताएं, हम बंदे भेज देंगे, मैडम इसको छोड़ना नहीं है। एंड ही यूज्ड टू आस्क मी एवरी मंथ, ही यूज्ड टू आस्क मी, ही यूज्ड टू रिंग मी अप, डॉक्टर आयशा क्या बना, आपने सोसाइटी का क्या किया। तो ये एक फैक्टर जरूर था, इसका मैं मेंशन जरूर करूंगी। अच्छा जी, अब हम प्रैक्टिसिंग फिजिशियन है, ऑब्वियसली ओवरलोडेड हैं, तो लीगल एडवाइजर और सारी पर्सनल डॉक्यूमेंट, जैसे सर ने बताया कि हमें, सर ने एक में मजे का आगे आएगा, मैं आपको दिखाती हूँ। तो अच्छा खैर, वी हैड अ टीम ऑफ लॉयर, फ्रेंड्स, टीचर्स एंड ऑब्वियसली फैमिली। तो जब बहुत ज़्यादा परेशान हो जाती थी, कभी कभी सर शहबाज को कॉल करके इनके साथ में शेयर करती थी चीज़ें। सर को ये नहीं बताती थी परेशानी क्या है, लेकिन सर के साथ में 2-4 बातें करके, सर के 2-4 सुन के जुमले, एडवाइजेस सुन के मैं रिलैक्स हो जाती थी, और इसीलिए मैं इनको अपने बाप की जगह भी मानती हूँ। अच्छा, उसके बाद हमने क्या किया, 2021 से ये जो ज़्यादा एंथुजियास्टिकली हमने शुरू किया, 2023 में वी मेड दिस व्हाट्सएप ग्रुप, और ये हमारा कैबिनेट का ग्रुप है। 2023 नवंबर 10 ये हमने व्हाट्सएप ग्रुप बनाया, 8 मेंबर थे इसके, यही 8 मेंबर जो भी आपके सामने हैं कैबिनेट में। और ये मैंने इनको सबको कहा कि वॉलंटियर वर्कर्स मुझे चाहिए, अगर किसी को कोई एतराज़ है तो अभी स्टेप आउट कर सकता है, वी वॉन्ट वरी। सर ने बेस्ट ऑफ लक मुझे किया, प्रोफेसर ताहिर जमील ने, जब हमने कहा कि आप आ जाएं एज अ प्रेसिडेंट। तो ये कुछ मैसेजेस आपके साथ शेयर कर रही हूँ ताकि आपको एक रियल फील आए उसकी। और ये जो बनाई हुई हैं सर ने, सर मुझे कहते हैं कि अगर आपको चाहिए तो मैं अपने बर्थ सर्टिफिकेट भी भेज दूं, क्योंकि हम सर को हर कुछ दिन के बाद तंग करते थे। सर अब हमें ये चाहिए, अब हमें ये चाहिए, प्राइमरी एंड सेकेंडरी के सर्टिफिकेट चाहिए, सर आपकी बैंक स्टेटमेंट चाहिए, सर आपके पासपोर्ट की कॉपी चाहिए, सर आपका हमें आईडी कार्ड की कॉपी तो चाहिए ही चाहिए, सर आपके घर का एड्रेस भी चाहिए। अच्छा, इतनी सारी चीज़ें मांगने के बाद सर ने छेड़ना शुरू कर दिया कि अब आपके ना 2-4 चीज़ें रह गई हैं तो वो भी मेरे से ले लो। तो मैंने कहा सर ठीक है, जब ज़रूरत पड़ेगी तो वो भी ले लेंगे। तो ये बायोमेट्रिक सर की ही शायद मैंने लगाई है, प्रोफेसर नाम ताहिर जमील अहमद, तो बायोमेट्रिक तक हमें हर जगह जाना पड़ा और देखना पड़ा। अच्छा, दिस वाज द डे, बड़े खुश थे हम उस दिन, 2024 जून 1, नाम फाइनल हो गया। नाम भी कितनी दफ़ा रिजेक्ट हुआ, कम से कम 10 दफ़ा नाम रिजेक्ट हुआ। हम नाम लेकर जाते थे, वो मानते नहीं थे, नहीं जी नहीं, ये नाम सूटेबल नहीं है, इसमें फलां लफ्ज़ नहीं आना चाहिए, इसमें फलां नहीं आना चाहिए, इसकी पब्लिक को अंडरस्टैंडिंग होनी चाहिए। अब मुझे ये बताओ कि डर्मोस्कोपी की सोसाइटी बनानी है, वो पब्लिक को कैसे समझ आएगा डर्मोस्कोपी क्या होती है? हाउ डू आई ट्रांसलेट इनटू पंजाबी और उर्दू व्हाट अ डर्मोस्कोप इज? बहरहाल, गोइंग थ्रू ऑल दीज थिंग्स, तो ये हमारा जो नाम था, इट गॉट फाइनलाइज्ड, और उस दिन हम सब बहुत खुश थे। सो वी मेड अ टीम। ये सारे हमारे जो हैं वो टीम मेंबर्स हैं। ये सारे क्यों मेरी टीम का हिस्सा हैं? क्योंकि ये सब लोग बड़े रिस्पेक्टफुल हैं, हम सब एक पेज पर हैं। अगर एक बंदा कोई बात कहता है तो सब सुनते हैं, उसको रिस्पेक्टफुली सुनते हैं, अंडरस्टैंड करते हैं, एंड देन दे टेक द मैसेज, और ये क्रेडिबल है सारे के सारे, एंड मोस्ट ऑफ ऑल सब में एनर्जी है। तो फॉर्चुनेटली वी गॉट दिस रजिस्ट्रेशन डन। ये SCCP का सर्टिफिकेट है जो मैंने डिस्प्ले किया है, और ये सारी एफर्ट जो थी ये इस काम के लिए थी ताकि कोई एक चीज़ हमारे हाथ में एक सॉलिड, एक हार्ड कॉपी की शक्ल में हो, कि जो रजिस्टर्ड सोसाइटी हो और जो रिप्रेजेंट कर सके पाकिस्तान को, नॉट ओनली नेशनली बट ऑल्सो इंटरनेशनली, कि येस वी आर हियर हु आर गोइंग टू टेक केयर ऑफ द डर्मोस्कोपी मैटर्स। तो उसके बाद हमने कहा इसका इवेंट करते हैं, वर्कशॉप करनी चाहिए, लोगों को सिखाना चाहिए। तो वी हैड फ्यू मीटिंग्स, ये हमने किंग एडवर्ड में की, अपने स्पॉन्सर्स के साथ कुछ मीटिंग्स हमने की। एक्चुअली बहुत सारी मीटिंग्स की, लेकिन कुछ बस मैं शो अप कर रही हूँ यहाँ पे। मेरे अपने वार्ड के मेंबर्स, प्रोफेसर जाहिदा रानी हैज़ बीन वेरी काइंड इनफ, और उन्होंने जेनरसली कहा कि जिस बंदे को जो काम कहना है तुम कह दो, दे आर विद यू, दे आर योर्स। और मैं इसके लिए मैडम की हाईली जो है ग्रेटफुल हूँ टू मैडम। और फिर मैंने सबको, इन लोगों को काम दिए, दे आर ऑल माई ट्रेनीज, PGs, मेडिकल ऑफिसर्स, कंसल्टेंट्स, हाउस ऑफिसर्स, ये सारे इधर बैठे हुए और एक बेचारे ऑन टोज थे, और सुबह डरते डरते जो लेट आ रहा था वो स्माइल भी नहीं दे रहा था, एक सोशल स्माइल। तो मैंने सुबह सुबह इन लोगों को थोड़ा सा ईजी भी किया। सो ये हमने अपना फिर डॉट्स का हमने लेटर पैड बनवा लिया, 27 अप्रैल डेट फाइनल कर ली। हमने वेबसाइट के ऊपर काफ़ी काम किया, अभी तो बेबी वेबसाइट है, बट इफ़ यू ओपन इट, dotspk.org, इसी के थ्रू आप लोगों की रजिस्ट्रेशन हुई हैं। तो हमने इसके ऊपर काफ़ी काम फिलहाल भी कर लिया हुआ है। फ्यूचर गोल्स हमारे जो हैं वो बहुत मज़ेदार हैं, लेकिन ज़्यादा टाइम नहीं लूँगी आपका। आई एम गोइंग टू एंड विद 1 or 2 स्लाइड्स मोर। तो हम मेंबरशिप अनाउंस करेंगे डेफिनेटली, डिजिटल प्रेजेंस हम ज़रूर अपनी इंश्योर करेंगे। दिस वर्कशॉप इज़ 4.5 hours CME accredited as well, and we are hoping to have more CME accredited workshops. The accreditation we have taken from King Edward Medical University, and we are hoping to have interdisciplinary webinars and annual newsletter हम निकालेंगे, और हम collaborations भी करेंगे। लॉन्ग टर्म गोल्स भी आपको सारे नज़र आ रहे हैं, उसमें ज़्यादातर हम जो है वो AI के ऊपर फोकस करेंगे। और इन सारे कामों में जो मैं समझती हूँ सबसे ज़्यादा जो बंदा ट्रस्टवर्दी था और जिसको मैं ऑर्डर भी दे सकती थी, इट वॉज डॉक्टर वजीहा नुसरत। एंड आई यूज टू टेल हर टाइनी बिट कामों से लेके बड़े बड़े कामों तक। और अभी पिछला एक हफ्ता आई वॉज वेरी बिजी इन सम अदर थिंग्स, तो मैं पिछला एक हफ्ता पूरा नहीं देख पाई। एंड वजीहा नुसरत इज़ द वन जिसने सारे मैटर्स को टेक केयर किया। शी इज़ लाइक अ यंगर सिस्टर एंड शी इज़ बिन विद मी, एंड आई बिलीव if you believe you can, you're halfway there. And this is what we have been through. And I can proudly say now we have an organization, we are going to take care of this. And inshallah, we'll reach out to every big city, every small city. And our plan is to make you more skillful, to, to make you learn this skill, जो कि बड़ी important है dermatologist के लिए. With this, thank you so very much. Life is about learning. When you stop learning, you die. And I believe you all should learn. And आज के जो सेशंस हैं वो मैंने बड़ी मेटिकुलसली प्लान किए हैं। डॉक्टर अस्मा नासिर आपको बेसिक डर्मोस्कोपी में मेलानोसिटिक नीवाई पढ़ाएंगी, प्रोफेसर बाबर राव आपको पैटर्न्स बताएंगे और कॉम्प्लेक्सिटी से सिंप्लिसिटी की तरफ लेके आएंगे, बिकॉज वी बिलीव कि ऑल ऑफ अस आर, ऑलमोस्ट 90% ऑफ अस आर न्यू लर्नर्स, नॉवल्स। तो हमने बेसिक्स इसको ज़्यादातर रखा है। सेकेंड सेशन जो होगा लंच के बाद, उसमें मेलिग्नेंसीज के ऊपर बात करी जाएगी। जो gist of dermatoscopy है, this is how to recognize pre-malignant and malignant lesions. So you just have to stick around. आज का दिन हमारा है, आज का दिन हमने आपसे ले लिया हुआ है। अगर कोई सोच रहा है कि वो लंच के बाद स्किप करेगा तो नो, लंच के बाद इज गोइंग टू बी अ बिग सेशन, और मैंने अपना सेशन रखा ही लंच के बाद है। सो लंच के बाद हम लाइव डेमोन्स्ट्रेशन भी करेंगे, हैंड्स ऑन भी करेंगे, और द बिग सेशन ऑन कैंसर्स वो भी करेंगे। प्रोफेसर बाबर राव का भी एक और लेक्चर लंच के बाद है। यू मस्ट हैव सीन द प्रोग्राम ऑलरेडी। With this, thank you very much. And Dr. Umar and Dr. Ima Shaheen, over to you again. Jahan bhi aap aake. Thank you so very much for your attention. You've been a great audience.
Thank you so much, Dr. Aisha, for your valuable insight about this very prestigious organization of DOTS. Now, I would like to invite our very worthy and respected professor, who is not a pioneer of dermoscopy nationally but internationally. He has been a pioneer of dermoscopy internationally. He has been a professor of dermatology in Rutgers University, Cornell University. He graduated from Rawalpindi Medical University, but then became a fellow of American Academy of Dermatology and also a professor of dermatopathology in the US.
For me, I would say that dermatoscope is just like an iPhone. We are all up for buying iPhone for a huge amount of money. As long as you have money, you can buy an iPhone, but then you should be knowing how to use it. Otherwise, just a wastage of money. Same holds true for the dermatoscope. You can have it in your hand, but as long as you don't know how to use it, it's useless. But once you know how to use it, it's worth it. And for making us knowledgeable and for understanding the basics and the advanced level of dermoscopy as introduced by Dr. Umar Mushtaq, Professor Dr. Babar Rao. Thank you, sir, for coming all the way from America.
A big round of applause for Professor Dr. Babar Rao, who has come all the way from US.
Thank you so much. Good morning and Assalamu alaikum. First of all, Aisha and Rabia and Aima and Wajiha and Shavana. And there is always a man behind a woman. So Zargam, who gave me a ride last night. So honestly, I have been, obviously, I do dermoscopy, dermatology everywhere in the world. But this is great. इतने सारे लोग जो सुबह सुबह dermoscopy सुनने आए हैं, that means when we talk about dermatology, the cardiologists or surgeons, they usually say you are very superficial. But by learning dermoscopy, we are getting deeper into it. And if we keep learning, we will get into pathology and we will get even deeper into it. यहाँ पे जो प्रोफेसर साहब बैठे हैं इधर, my recommendation to all of you is stay close to them, learn from them as much as you can, because all of us are at an age where our battery may go off anytime. So before that happens, get a USB drive and get this knowledge out. So thank you to all the professors. How do I? So I'll skip some of these slides because Aisha has taught you all these. And by the way, I propose that Aisha should run this country because she's doing so good that she can run the country. So in dermoscopy, this is a common word like polarized versus not polarized. Why do you want to use polarized? Because you can see deeper structures basically. So here few example, but let's go beyond that. So initially when we started dermoscopies, late 90s, everybody was trying to figure it out कि अच्छा देख तो लिया है, then how do we interpret in reference to के patient का क्या कर रहा है. Then there was a lot of these algorithms, ABCD, Menzies and 7-point and so on and so on. So when Academy of Dermatology started teaching dermoscopy, जैसे कि यहाँ पे आज हो रहा है, we started with basic dermoscopy. And then a year later, they started advanced dermoscopy. Advanced dermoscopy में ये हुआ कि जो लोग उधर बैठे हैं, they're listening to you all and me all, और उसमें फैसला नहीं हो सक रहा कि इसको ये डॉट है कि डॉट नहीं है, ग्लोबुला के ग्लोबुल नहीं है. So that complicated the matter and it becomes more complicated कि देख तो लिया है, अब इसका करना क्या. So then I went back, I said, I'm leaving advanced dermoscopy. I went back and I wrote my own chapter, my own book, my own way of learning dermoscopy. So that's what we will learn. So basically, very simple. Okay, there are patterns on this left side and there are patterns on the right side. If you see any of these, we'll show you example. You don't biopsy because tumors में what matters is कि आपने biopsy करनी है कि नहीं. Doesn't matter कि वो basal है कि melanoma है. As long as you biopsy, you save the life. So if the patterns are these ones, which are reticular, globular, we'll show examples. You don't biopsy. If you see any of these, you just biopsy. So this gets as simple as that कि अगर patterns आप ये याद कर लें जो कि ये लेक्चर होगा आपके पास, आयशा कैन गिव इट यू ऑल. So then similarly, few more, if you see these one, black dots, brown dots, blue-gray dots, blotchy, that's you don't biopsy. If you see those ones, we'll show example, you biopsy. So as simple as that, if you cannot understand or learn or nothing else, these patterns we don't biopsy, these patterns we biopsy, and we'll go through these patterns. And this is already published work by my friend Ash, and he was fellow with me in Dermoscopy. So basically, what is a reticular pattern? It's a network-like pattern, globular pattern. If these dots go around that, we call reticoglobular. Homogeneous mean homogeneous, patchy network, comedon-like structures, mouth-eaten border, and honeycomb, and so on. On the other side, we have those patterns. So this is already published. You can go check it up. But this is what we'll be using in the definition, non-biopsy patterns. And then biopsy patterns. If you see any of these, we're going to biopsy it. Negative pigment network, arborizing vessel, leaf-like areas. All these you already know, but basically these are definition, and you want to look at them. If they look any of like this, we're going to biopsy them. So now the teaching is over. There'll be patterns you don't biopsy. There are patterns you're going to biopsy. Now we're going to review all of us together, and you're going to tell me biopsy or not biopsy. If not, I have Shamana and Eliza sitting in front. I'll just keep asking them. Okay, so this is clinical. Let's go to dermoscopy. So biopsy or not biopsy? No biopsy. And if you say no, we also going to say why no. क्योंकि dermoscopy का फायदा ये है कि जब आयशा वगैरह जो इनके उस पे WhatsApp ग्रुप में, if you say I think it's basal cell, somebody will always say why. So you have to explain why. तो इस केस में okay, no biopsy. So why no biopsy? Because it's a regular pigment network, and that's it. ठीक है कि अगर जब आप कहें पेशेंट को या अपने फेलो कॉलीग को कि दिस लीजन डजंट नीड अ बायोप्सी, यू शुड बी आल्सो एबल टू एक्सप्लेन व्हाई इज दैट. सो दैट्स व्हाट वी आर लर्निंग. सो नो बायोप्सी. सो बायोप्सी और नॉट बायोप्सी. अगर समझ नहीं आ रही ना, इट्स बेटर टू से बायोप्सी, क्योंकि पेशेंट को कोई नुकसान ना हो जाए. सो बायोप्सी और नॉट बायोप्सी. ओके. So why? Because remember, our formula was if lesion has multiple colors, simple agar light brown, gray brown, brown hai, more than one colors we're going to biopsy. But this has two features, asymmetrical pigmentation and multiple colors. So we'll biopsy. It may come back very dysplastic nevus or so, but if you see these, we're going to biopsy. All right, biopsy or not biopsy? Some people are saying no. So, all right. So it's just a blue homogeneous pattern, जो कि blue nevi में हो सकता है. Sometimes hemangiomas can look like this, but it's benign. Biopsy or not biopsy? This obviously everybody will biopsy. इसके लिए dermoscopy की जरूरत नहीं है. जब but teaching point कि what are the features? So now this has all the features: multiple colors, asymmetrical, atypical globules, bluish white veil, जो आयशा ने सबसे पहले सीखा. So this has all the features. So we will biopsy. अच्छा, इसमें ये हो सकता है कि we are thinking this melanoma, it is melanoma. But let's say if you were wrong and it came back pigmented basal cell, उसमें अपनी इज्जत बेइज्जती का कोई मसला नहीं है. As long as we biopsy, we biopsy. So sometimes people fight 5 days about basal versus melanoma, but you biopsy, you biopsy. अच्छा, biopsy or not biopsy? No biopsy. Okay, because it's just a simple thing. Absence of any atypical feature, it's a globular pattern, very common children, congenital nevi. Uh, Whenever the time is over, please give me an indication because I have a lot of slides. So biopsy, yeah, this is a halo nevus or halo-like nevus. So biopsy, not biopsy. So no biopsy. क्योंकि ये जो जैसे ये halo बनता है ना, तो all dermatologists, patients everywhere, they get a little bit scared. It's a natural phenomenon. Lymphocytes try to come up, attack some pigment, create the halo. That doesn't mean it's melanoma. You still look at the structure, and if they are benign, then it's still benign. Okay, biopsy or not biopsy? Okay, a lot of people saying biopsy. So it has atypical pigment network, so we will biopsy. तो इसमें याद ये रखना है कि जो भी आप लीजन देख रहे हैं या आप कह रहे हैं कि बायोप्सी करनी है या नहीं करनी है, जस्ट कीप थिंकिंग कि क्यों आप कह रहे हैं जो कह रहे हैं, एटिपिकल पिगमेंट नेटवर्क और जस्ट दैट, सो दैट्स द इंपॉर्टेंट पार्ट. So biopsy or not biopsy, everybody will biopsy. This has everything for a bad lesion, and in asymmetric pigmentation, multiple colors, and everything else. So this obviously you will all biopsy. इसमें सिर्फ एक वो है, सम टाइम अगर बायोप्सी करें और nevus recurs, sometime it can look like a scar in the middle, but that will be obvious from the history, but this is a malignant lesion. Sorry, I'm going to skip some of them. So biopsy or not biopsy, इसमें just remember के this is like atypical pigment network. It has more than 2-3 colors, so technically according to our formula, ASAP formula, should be biopsied. Sorry, it skipped. So bluish white veil and atypical pigment network, so we will biopsy. At this point, anybody have any questions? Okay, what I'm doing, why I'm doing? B. Okay, okay. So this one, somewhere on the face, you really don't need a dermoscopy for this. It looks ulcerated lesion. You should be biopsied, but if you look at it, you will biopsy because it has ulceration and some arborizing blood vessels. This one, this happens throughout the world, from like Pakistan to Bangladesh to America to Brazil. जहाँ भी जाए ना, जैसे lesion किसी palm और sole पे आए, everybody gets scared. Oh, okay, कुछ हो गया. Parents, patient, everybody. Lesion, are almost all lesion in younger age children are benign on acral sites. And now it is believed that acral melanoma usually starts as melanoma. It is very uncommon for an acral nevus to become melanoma. Data is clear. So अगर कोई बच्चा या whoever मोल के साथ पाँव पे या हाथ पे आए तो there is nothing to get scared. It's just another mole. तो उसको एकदम से काटना ना शुरू कर दें. So this looks little bit clinically नहीं बता सकते, but you go here. So biopsy or not biopsy? Okay. So this one somehow is a difficult lesion. I'm going to skip it. Let's look at this one. So it's a small little 5 millimeter little reddish little papule or something. So this is not biopsy. अगर इसको आप थोड़ा सा scrape करेंगे, you'll see blood underneath. So this is trauma induced, but it can, if you go back, patients come all the time, 2-3 weeks ki history hai, it looks brown or it looks reddish, but this is just a hemorrhage. Now this one on the other hand, biopsy, okay. So we will biopsy because that's everything. How about this one? So this is 20% of your teaching this morning. This is somewhere on the heel or a foot of a patient. So we biopsy or not biopsy? Shawana, biopsy or not biopsy? Biopsy. Aliza, biopsy or not biopsy? So याद करने वाली बात ये है, we will go to the next one. So we call it a parallel ridge pattern. Ridge R से. So residents को पढ़ा रहे होते हैं, but they're on mnemonics they memorize for boards. So furrows are friendly. Furrows होगी जो इसके in between ये lines हैं. तो यहाँ पे अगर pigment होगी, they are skinnier or thinner. But if they are in the wider area, we call ridges. So ridge pattern is a malignant pattern. So this we will biopsy. This probably acral melanoma or acral atypical lesion. So remember the ridges, and ridges are wider. That's it. Agar thin lines हैं, you leave it. If it's a wider line, you will biopsy it. तो इसके बाद acral आपके मोल खत्म हो गए. This is easy, you all know. Biopsy or not biopsy? So it has those arborizing vessels, some white streaks. So this is your basal. This is a difficult lesion. I don't know who, maybe Aisha gave it to me for some presentation, or maybe I forgot. But this is a deep lesion, जिसमें you have some vessels and multiple colors. So theoretically, According to our formula, we should biopsy it because we don't know what it is. But this happened to be otherwise a cyst. But I mean, I wouldn't clinically look at it and say it's cyst, but if you see this, you will biopsy it. This I will skip. Anybody biopsy or not biopsy? So according to our formula, it has arborizing blood vessel, it has some white streak or scar-like area, so it deserves a biopsy. Basal. Okay, biopsy or not biopsy? Okay, so by now you have already learned that which one to biopsy or not biopsy. This is probably a basal. Biopsy or not biopsy? Easy lesion, but can be difficult if you don't know. So biopsy or not biopsy? So this is just a hemangioma. Another one. Okay, somewhere on the face. So these are those difficult lesions. जब ये देखते हैं, is it lentigo, is it pigmented actinic keratosis, or it is seborrheic keratosis, or lentigo malignant? This is always a question. So in this one, basically, if you see this area, which are, we call it follicular opening, face पे है, there'll be follicular openings. So this has enough like red pseudo network like pattern जो कि pigmented actinic keratosis can have. But if you go to next one, how many people want to biopsy this? So we have moved away from melanocytic. We are now in keratinocytic zone. So biopsy or not biopsy? So this would be your possible squamous in situ or advanced AK or early SCC. So dotted vessels with scale or strawberry vessels, we call them, we will biopsy it. How about this one? Anybody biopsy or not biopsy? So same thing, scale and dotted vessels. Bones disease or AK, okay, same thing. So biopsy or not biopsy? Okay, you have already learned. So biopsy or not biopsy? No? Okay, seborrheic. How about this one? So this teaches whole melanoma colors. इसमें सारे features हैं. Base multiple colors, irregular pigmentation, blue white veil. So we'll biopsy. Biopsy? Okay, we will biopsy because it has all the features. In situ. Biopsy or not biopsy? Okay, we will biopsy. This one is funky one. Anybody not want to biopsy this? Biopsy or not biopsy? So this is a little bit difficult. It look like a spoke wheel like pattern, but scale bhi hai, thodi ulceration bhi hai, but either way, enough feature to biopsy. This happened to be a little crusted basal cell. Biopsy or not biopsy? Okay, so we'll biopsy. Biopsy or not biopsy? So face pe we were talking, this has follicular openings, but all follicular openings don't mean कि ये एक ही होगा. So this one has obviously irregular pigmentation, accentuation around hair follicles. So this is lentigo maligna most likely. So biopsy or not biopsy? Okay. So now we are back to the foot or palm. Remember we had parallel ridges where the pigment was in between these two lines. And they were thicker and wider. We call them ridges. Those are malignant patterns. So this will be furrows, which are friendly. Furrows are friendly. And this is no biopsy, parallel furrow pattern. This is all skip. Okay, so I stop because this goes into nail. I would want people to ask me questions. Basic pattern. And one more time, on one side you remember or memorize in your head कि कौन से pattern जो कि common benign pattern and we don't biopsy. On the other side, like spoke wheel, vessels, atypical pigmentation, apical network, blue-white veil, dotted vessel, all those you will biopsy. So Anybody have any questions? Or Tahir Saab or anybody? Aisha, anybody? Yes. So that's a question is कि how long should you follow up के क्या होगा? So in United States is different. अगर मैं एक लीजन देखूं और मुझे ये लगे कि ये benign and then it's fine, but if I'm worried, when should you follow? In my notes, I'm never gonna write follow up in 6 months for that lesion. क्योंकि अगर वो melanoma हो गया, उन्होंने कहना you were worried, why did you not take it out? So what I would write in my notes is like follow up for routine skin check, not follow up for this lesion. Because if I was worried, why didn't I remove it? एक बंदा very famous dermoscopist got sued. उसने ये लिखा था. So if you see a lesion, either you biopsy or you not biopsy. Don't say we will follow this particular lesion. That technically become difficult. But on average, usually we do once a year. If patients are high risk, we'll do like every 6 months. Or Australian studies, if a lesion has to change into melanoma, usually it's 4 to 6 months to go to in situ. So 6 months is good. G. Yes. So just brown color. Okay, मुझे समझ नहीं आ रहा उनको जरा कोई speak दे. हाँ. Yeah. No, multiple shades of brown or multiple shades of gray. Multiple shades of brown is still not good. Light brown, dark brown, another brown, that's already two colors. That means the lesion is changing, we'll still biopsy. तो एक क्वेश्चन होता है जो डिस्प्लास्टिक नी वाई वी बायोप्सी मोस्ट ऑफ द टाइम के नी वाई में स्पेशली देयर कुड बी सेंट्रल hypopigmentation, central hyperpigmentation or peripheral, but that doesn't mean anything ke central or peripheral. If it's uniform network or global, we still leave it alone, still benign. G. G.
What is the practice in US? I mean, how percentage kya hai of the dermatologists that are traditionally using dermatoscopy in their clinical practice? Are you guys having it all with you all
I
time?
mean, digital or nahi? Or dermoscopy?
Dermatoscopy, yes.
So dermoscopy, the rule is if you don't have a dermatoscope that day, you don't look at moles or lesion, tumors. Inflammation dekh lenge, but I feel like if I don't have a dermatoscope and I'm looking at a neoplasm, I'm not doing a justice to the patient. So I'd rather have them come back or I biopsy it. So almost now we did this study like 15 years ago or 18 years ago when only like 50-60% were using. Now I think 90% dermatologists they use dermoscopy. But I'm really happy to see the effort your team has put in. And first time doing this, I love the name two dots. It look very digital, very modern. But I think I'm happy that you guys started this because then it will lead to other things like digital and teledermatology and AI and everything. But I think and confocal eventually. Next year, if Aisha invites me, we'll have a little session on other non-invasive diagnostic thing other than dermoscopy.
Sir, I would like to ask two questions. The first
Ji.
one is that in America, in your setup, is it being taught as a part of routine curriculum in dermatology training, like once you are going for the board certification?
Yeah. So in board exam, there are many questions which are dermoscopy. So it is you must learn it. There is no way out. They have to learn it. जैसे psoriasis सिखा रहे हैं, you have to learn dermoscopy also.
So we are planning to make it a part here. The second question is, once we come to the dermatohistopathological correlation, as
Ji.
I initially got introduced to you as a
Ji,
dermatopathologist,
ji.
how much of that is there?
I think
How accurate
the
it
way
can
I
be
mean
through the dermatoscope?
they attend my by the way for everybody Aisha was gonna announce I have an email we'll put it up there Every day we sign cases live on digitally. Anybody interested, contact Aisha and she'll put you through. But basically what we do is जब हम skin pathology देखते हैं, first we look at the skin pathology, पता नहीं लग रहा है कि ये basal है कि psoriasis है कि नहीं है, blistering disease है. Then usually I ask my fellow, let's look at the truth. And the truth is the dermoscopy photo. So then we'll go back and match कि ये does it match or not. So it is very important जब आप कर रहे हैं कि जब dermoscopy देखें अगर pathology है और other way around जो pathologist देख रहा है उसके पास अगर dermoscopy, it makes so much sense to put it together. जी.
So I'm also part of that forum, and we are planning on making a clinical dermatopathological, histopathological correlation, or maybe an atlas or research in future. So your guidance would be required.
I think it's very much needed and it's a good way to learn for जो जब हम grand round दे रहे होते हैं, usually what we ask is कि if there is if this is a papule, so tell me what is this papule made of? A papule could be made of nevus cell, sarcoidosis to amyloidosis or just inflammation, or it could be spongiosis or it could be hyperkeratosis. तो student ने सोचना ही होता है कि ये जो papule है what is made of. So if you can think that, then you can relate that with clinical and dermoscopy and pathology. If there is a papule, what is the papule made of? जी, जी. We good? Thank you, ji. Thank you so much, professors and the organizing team.
Uh, I take the liberty for a minute that this time while we were just doing mock examination at the Center of Professor Faria Services, we had a station made for dermatoscopy. So very soon it's going to be one of the talk stations sometime in your examinations as well. So that's why before we started examining, we have started teaching you. So be part of it, and maybe in your examination, it may be one of the stations. Thank you.
Thank you, Professor Babarao, for an excellent enlightenment on different lesions. Now, our next worthy speaker is also from another country. She is basically a fellow from FCPS, but then she moved to the UK and now currently serving as a head of teledermatology of University of Western and Bristol.
Here, I would like to say thank you, Dr. Baba Rao, for making us a little more knowledgeable. And I am proud to see that most of you are able to figure out that where should be a biopsy done and where should it not be done. And the credit obviously goes to Dr. Aisha Ghias for putting all this together. And another important thing for the trainees who are here, the dermatoscopy is going to be a part of your exam. So don't put it aside and don't leave it in the choice. It's going to be very much there. So as Dr. Umar Mushtaq said, that our next presenter has come all the way from UK, but she is very much a part of us, and that makes us proud that our people are serving so well. And her name, I would say it in the end, she is a graduate of King Edward Medical College, and then she did her fellowship in dermatology from Lahore General Hospital. And we are proud to have the supervisor, Dr. Atif Shahzad, here. So you can see that you have produced such useful uh, postgraduate
We
trainees.
would like to invite Dr.
Dr.
Asma
Asma
Nasir on the
Nasir,
stage.
and she'll be making us more knowledgeable like, regarding the dermatoscopy in melanocytic lesions. Dr. Asma, please.
Assalamualaikum. I'm Dr. Asma Nasir. So I am familiar to few, but maybe unknown to most of you, I think. So I'm Asma Nasir. I graduate of King Edward Medical College in 2005. Aisha and I are class fellows, so if people don't know. So that's the connection. I'm here today. I'm fortunate that I was able to work in two continents as dermatologist and as consultant dermatologist. I started my journey in Pakistan in 2011 in dermatology and joined Lahore General Hospital in 2013 as trainee with Dr. Atif Shahzad. And it's a very, very emotional and overwhelming moment today that I'm here sharing a stage with him. Then I moved to UK in 2019, and where I think my journey started with dermatoscopy. Can we go on to the first slide, please? So the topic was given to me was very interesting, the art and science behind the melanocytic nevi, because the science combines the knowledge and art is the one which present into a aesthetically visual platform. And I think its Dermoscopy is already a beautiful combination of both. And it's a very wonderful interactive tool that we have at our disposal as dermatologists, which is very, very helpful. Currently, I'm working as a University Hospital, Bristol and Weston, and leading the telederm. And in telederm, the dermatoscopy is integral part of the images. So I would like to keep it interactive. So if there is any question, please do interrupt me, and I would be very happy to answer those. And we will start with the classification of melanocytic nevi. The classification has changed. Initially, it was clinical, morphological, and now because of dermatoscopy, we have been fortunate that there are studies to classify the patterns on dermatoscopic basis. So as Dr. Tahir Jamil, Professor Tahir Jamil told us that the first dermatoscope looked like that. And it was, I think in 1600, someone made that. And they were also producing published work at that point. So I think that's bravo to them. Now things have changed. They are more smart and interactive, bedside accessible. And this was the first dermatoscope that I brought in 2019 when I started my work in NHS. That was Heine Delta 10. At the moment, I'm using the Dermlight, which has both contact and non-contact mode, a polarized and non-polarized section. And we also have access now to the Casio dermatoscope, which has a digital platform, and it combines the UV mode as well, which has some implication in aesthetics. So things are combining more as we move forward. This slide is talking about just the basic principle. So what a contact and non-contact dermatoscopy means. In contact dermatoscopy, you have to put the dermatoscope onto the skin because it creates a difference into the refractive index between skin and the air. So things and the light do get reflected, and it's not a very good use of the light that we see. So they have now built in the polarized and non-polarized mode. So they can then filter. I think I'm missing here something. So that's without a dermatoscope, without any interface. The light is passing onto the skin, and it's mostly reflected, and you can't see much because there is glare. So once you put an interface is a gel medium that you use between skin and the dermatoscope. So it does then let light pass into the superficial layers of the dermis, and then you can view them on dermatoscopy. So in polarized light, what we do, if I'm pointing to the right picture, I think, what we do in polarized light is then we also filter the shorter wavelengths, and we can see the superficial dermis more. So the vascular structures are more visible in polarized light, and non-polarized light, we see the superficial skin structures. Next slide, please. I'm unable to use this. Sorry. Sure. Okay. So once you start using dermatoscopy, I mean, it speaks to you in its own language. And once you start reading or learning a language, it's always good to start with the alphabets. So there are structures, which are just the geometrical structures that you see: line, circle, pseudopod, dots, and circle. And these structures, they form then a pattern. Next slide, please. They form a pattern on dermatoscopy that you recognize with certain anatomical parts of the skin. And then you classify again on their distribution. Sorry, we have lost. On the distribution. The next slide is again showing what are the main dermatoscopic structures. So I will just stick with the nevi here and wouldn't go into the melanoma. With the nevi, we normally see reticular network, globular pattern, and then homogeneous blue and brown pigmentation that is very specific to the melanocytic nevi. Can anyone tell what this is, please? If I just tell the history, she was on a 78-year-old female. She said that it has grown recently, but present for lifelong. We will just a melanotic melanoma. I mean, that's quite variable responses that we have got. So I think we will just park this thought here and we will get back to it, because I think we may be able to more knowledgeable once we discuss what to look for when we are looking for nevi. This is my own handwritten note that I have produced after reading a lot of papers and I would say website, that how do we dermatoscopically classify our nevi? I mean, on morphology, we do classify on congenital, acquired, and then we then classify dermal, junctional, and compound nevi. So dermoscopically, we do classify them on globular nevi, reticular pattern nevi, spits, starbursts, blue, site-related. They could be acral, facial, subungual, on lips or nipple. Or there are some nevi that are associated with specific features, like they could be combined, halo, irritated, coccate, mycin, or they could be recurrent nevi. And there are still some unclassified melanocytic lesions like melanocytoma, but that's another minefield. I mean, it's not the remit of this presentation only. Next slide, please. So that's again the repetition of the morphology classification that we see. Next, please. This slide is just signifying the congenital melanocytic nevi. As we see, there could be small, medium-sized, or giant melanocytic nevi, and they depend on their diameter. A giant is called if it's more than 40 centimeter, and the incidence of melanoma is roughly about more than 20%. Do we know the incidence of melanoma in our skin type in Pakistan? Does anyone has worked on this database? How many melanomas you have seen practically? I mean, I didn't saw any melanoma when I was working in Pakistan. So it is a common practice now. Okay. Right. So, I mean, the melanocytic nevi that we found in darker skin population, the incidence is still low and it's worldwide. It's less than 1%. But if they are on a skin type 1, 2, or 3, or lighter skin type, the incidence is high. And it's even higher if a person or a child is born with these giant nevi, it goes up to 40%. And because melanocytes, they have a neural embryogenic origin. So whenever you come across in clinical practice, I think pediatric dermatologists would know this better. If you see something like this, then you have to be alert that it could be in the brain, leptomeninges, or even behind the eyes, choroid. So you have to make sure that you have appropriately investigated or even referred to a specialist center for that child. So this I've taken from Bologna because I like this simple flow charts because I'm a very simple-minded person. I have to be guided by what to do this next if I come across a scenario. So if there is a giant congenital melanocytic nevus, you have to do a neurological exam and request an MRI, and you may have to do it serially to make sure that you're not missing anything and even prevent some potential complications. So acquired melanocytic nevi, they again depend where they are on the dermis, at the junction or into the superficial dermis or epidermis. They are called the dermal nevi, junctional, complex, or papillary reticular nevi. Next slide, please. This is again a very old and very frequently used slide that the pigment and the color depends where it is in the skin and then how it's look like. The blue, purple, mauve, they're all related with the deep structures and it is embedded into the deeper layers of the skin. So Spitz nevi, it's a very, I would say, good topic. Spitz nevi, it deserves a presentation of its own because I always excise Spitz nevi. I find them very unsettling. They are very unstable, and the pattern is that you do see growth um, around the lesion, and the growth normally significance is when you see these globules around the periphery or some streaks. That's always an indication of growth in a melanocytic lesion, and I excise it normally. But you can leave it alone if it's a very experienced eye and you are confident that you can monitor and the patient is reliable. Blue nevi, I think, have to have quite patience once you get to that experience that you can leave a blue nevi because they do have a blue veil and a cloud around them, which signifies that the cells are just embedded deep into the dermis. But once you, I would say, are quite experienced, then you can leave them alone and just reassure. And the history also tells that it's been there for a long time and it's not something that has developed very recently. So now we are moving on to the nevi of the special sites, and topmost is the acral. Moles on sole of the feet, they are a minefield, and you need to be very careful. As Dr. Babar Rao just said, that fibrillar pattern is fine, but ridges should make you frown. So if the pigmentation is in the ridges, you have to be very mindful that it could be a melanoma. In the lower section here, this one, it's a congenital nevus. It's a congenital nevus. The clinical and the dermoscopic images is correlating. The pattern is multiple. I mean, it's multi-component nevus. It does have fibrillar pattern and cobblestoning, or as we call it, the globular pattern, but it still has symmetry in its multi-component structure. So it was a congenital nevus. It was biopsied, but it came back as benign. So any question on this slide? Because this took me a long time to make sure that I am very well versed with the acral melanocytic lesion. They are difficult when I started them. Any question on this? Because there should be. This is also benign pattern. This is benign pattern. Sure, please. Sure, Dr. Shaikh.
First of all, I'll take the liberty that I'm extremely, extremely happy to see you on stage.
Thanks.
And sharing it with my supervisor also. So it's an honor for a Department of Dermatology, Lahore General Hospital. Thank you, Dr. Aisha, for providing the platform. The question is, Asma, that you were saying that furrows are friendly and ridges
Are unfriendly, yes. They're rude. Ridges are rude, yes.
I love the acronym, but I was just curious, what about the central figure? There's a brick pattern.
Yes,
What do they indicate?
Sure. And these are the sebaceous openings. I mean, in palms and sole, these are the spacious openings. So basically, the pigment should follow the furrows. And depending on the anatomical foot and how someone bear their weight on their feet, they can develop these patterns. So this is the lattice. This is common. Um, Again, it's gone, sorry. This is the fibrillar pattern. This is the parallel furrow, which is the classic of benign lesion. So in next slide, I have just told you the variation. So it's all pigment. It's just where people are bearing their weight. You see those pattern, and they're all melanocytic nevi. None of them was suspicious or melanoma. So lattice pattern we see in the insole. In exact weight bearing areas, we see this fibrillar pattern. So everything is just fuzzy. And the normal good looking furrows, as we say, we just inside the area, which is not weight bearing, but just adjacent to that. So we see the typical pattern there, but all the other areas, the melanocyte just disperse because of the weight. So that's a very billion-dollar question, because the skin of color is a buzzword nowadays in dermatology, because not much work has been done before. All of our atlases, textbooks, they were in white skin color, because it's just that things and colors and pattern look quite obvious in skin, lighter skin tone. Yes, they should stay the same, but the thing is, when you have a background pigmentation already in skin, it's hard to differentiate, and you really need an eye of experience. I mean, even I would say, working with world-class dermatologists, most people, when it comes to skin of color, they do get twitchy and fuzzy, and they say, I don't know, and then they call, oh, asthma. Have you seen this? I said, yes, I have seen this. So this is exact acral melanoma. So it would have the widespread ridges and other pattern, but again, the ugly ducting, things are not making sense. There is chaos. So whenever there is chaos, because things are symmetrical when they are, I would say, normal, whenever there is chaos, it should make you frown and think about your clinical decision, whether I'm happy to leave this lesion alone, or I would like to do something investigatively. So mucosal nevi, that's again something, they do look different. They have these very fine lines. They are seen on mucosae. And you have to reassure them. I mean, it's not something that we won't see in clinic. It's quite often. Please, people do come with melanocytic or macules on the lower lip because of the UV exposure, and it's quite common in skin type 1, 2, and 3. You have to reassure them.
Respected Dr. Asma, actually we are short of time, so we have
I
to
think
cut it
I
short.
would be rushing. Can I have 5 minutes more? Sorry about this. So facial lesion again are different, because face has a pseudo network pattern. It has hair. So things do look different on faces. So once a nevus is on the face, it do look different. And normally faces have dermal nevi. They are spongy. If you touch them, they're soft. They're never firm. That's an indication that it's a nevus and it's not a tumor. Because if it's a BCC and a dermal nevus, you can differentiate just by palpation. Because the mole would be spongy, squishy, and nevus, the BCC would be very firm. Next slide, please. Nevus pilus, I think most of us has seen. It's just a pigmentation over a pigmentation. They are usually benign. You can just leave them alone. And the pattern is reticular, which shows that they are acquired. Next slide, please. Halo nevi, they depends on the evolution. Some people do biopsy halo nevi all the time, but it depends on the context. If a person has a previous melanoma and they have developed halo nevi, then I would biopsy it. But if it's a child, a growing